So please may I just introduce for some opening remarks Dr. Amanda Thompson. She's our National Speciality Advisor for Older People's Mental Health. And then we'll go into my slides and just tell you a bit more about the toolkit.
Firstly, I want to thank Dr. Humphrey and Colin Sloan and the wider team for putting this webinar together. You'll be pleased to hear I'm going to be very short. But the management of distressed behaviour in people with dementia is a really important challenge for primary care and mental health services. Data that is regularly collected nationally about the percentage of people with a diagnosis of dementia who've received a prescription for an antipsychotic medication show that in August this year, it was 9.16%. There is, however, regional variation from 10.53% to 7.94%. But this variation is even more apparent at the ICB level, and I know that Sarah will be going on to discuss this later. But out of 42 ICBs, so those are integrated care boards, 23 are above the national average, with a couple being over 12%. So why is addressing antipsychotic prescribing so important? We know that antipsychotics can have a devastating impact on someone with dementia, and that we should try and avoid prescribing them if at all possible. And that's where this wonderful toolkit comes in. Distressed behaviour in someone who has dementia is in essence a communication of an unmet need. And if we can meet these needs, then the behaviour should reduce. And this toolkit gives a wealth of suggestions of various non-pharmacological evidence-based approaches that can be used to reduce the distress. The toolkit also is extremely useful should an antipsychotic be needed, because it helps guide the clinicians on the factors that should be taken into consideration around initiation, continuation, and importantly, discontinuation of antipsychotic treatment for people with dementia. We know that if a person with dementia is prescribed an antipsychotic medication, this is often not regularly reviewed, and they can remain on it longer than is needed. I know that Sarah is going to run through the toolkit and explain its use in detail, and there'll be a chance to ask questions. Once again, my greatest thanks to the team for the huge amount of work that's gone into developing this resource. I'm now going to hand back to Sarah.
So we've got about 15 minutes, and I'm going to just explain to you a little bit about the toolkit, a little bit of the reasoning why we developed it. It's not going to tell you everything about antipsychotics, and it's not going to tell you everything about the toolkit. It's just an introduction. So what I'd like you to do, and I can see lots of people have already told me who they are in the chat box, but please now start to think as I'm talking about any questions you might have, any comments that you might have. And then we've got half an hour after that when we're going to open up the floor. We may take questions off the chat box, we may ask you to speak. And it's just that chance to just have a bit of a conversation about it. So what we're going to cover is a little bit about why we did develop the toolkit, and then I'm going to run through just a little bit about the sections of the toolkit. It's not exhaustive because I didn't want to put them thousands of slides for you to see, but just telling you roughly what was in each section. So Amanda has introduced the session, and I thought I'm just going to set some sort of basics really, so that we all know what we're talking about. So when can antipsychotic drugs help with somebody living with dementia? Well, drug trials have shown that risperidone has a small but significant beneficial effect on aggression to a lesser extent psychosis for people with Alzheimer's disease. And these benefits or effects are seen when a drug is taken for a relatively short amount of time, 6 to 12 weeks. But we also know antipsychotic drugs do not help with other behavioural and psychological symptoms, such as distress and anxiety during personal care, restlessness, agitation, repetitive vocalizations, walking, social withdrawal, and changing levels of inhibitions. For example, if people are saying or doing things that are inappropriate. These behaviours, these changes, are more likely to need a personalised non-drug approach. Which antipsychotics are used for people living with dementia? So risperidone and haloperidol are the only ones that are licensed and approved for use. Risperidone is licensed for short-term use of aggression in Alzheimer's disease if the aggression poses a risk to the person and they have not responded to non-drug approaches. Haloperidol is licensed for persistent aggression and psychotic symptoms in moderate to severe Alzheimer's and vascular dementia. Again, where non-pharmacological treatments are ineffective and there is a risk of harm to self or others. Now, we do use other antipsychotics for people living with dementia, and these are used what we call off-label, which means that we can prescribe them as doctors or prescribers if there is good reason to do so, and provided we followed the rules set out by the GMC. So that's the sort of background. That's what we're talking about. Those are the antipsychotics. And what I thought I'd also do is show you this one slide, which I use quite a lot, which shows, which talks about the possible side effects. So this is what we know is on that negative side. And often we lose sight of these. So they increase the risk of death, stroke, sedation, and these symptoms, and it can worsen other symptoms of dementia and of Parkinsonism. It increases the risk of infections, falls, blood clots, and the risk of ankle swelling. So those are all on the negative side. So we've just talked about when we can use them and why, and these are the negative side of them. I've got loads of slides normally that talk about the numbers, but we're just going to keep it really short today. So that's just the main slide. Now, Amanda talked about variation. Variation is important because it says that we are all doing different things. Some people are probably doing it better than others. And that variation means that we've got an opportunity to improve or narrow the gap between the best and the worst. So on this slide, you can see big, thick pink line going through the middle. That's England average, sitting about 10%. That means 10% of all people living with dementia are at the moment in the UK prescribed an antipsychotic. That's a lot, isn't it? But and there is variation between us. So we can see variation going up to almost 12% and down at the bottom at 7%. And you can see how antipsychotic prescribing has changed over the last couple of years. And we had that COVID spike initially. There is a big drop. You can all see in October 21, we changed the method of calculation. So it's not that we all suddenly got loads better. So that first slide showed you regions. This one shows you ICS areas. And you can see again that variation. And it isn't that some areas are really good and others aren't, but within areas we know that there is variation. This shows you some data from the London ICBs within the London network. And here you can see variation within Yorkshire and Humber, who were the other contributors to the toolkit. I work in Bradford, and I'm going to tell you right now, we're definitely on the naughty step there. We're sitting at 15%. But we sit side by side with, say, Calderdale down at 8.6%. You know, we have the same boundaries. We may have slightly different populations. Why have we got that variation? And that's why the toolkit's important. So why a toolkit? Well, it's complex. I don't expect you to be able to see the fish diagram. I just want you to see that it's really complex. We live in different places. We have different challenges. We have different resources. We have different local attitude. We have different community assets. We have different staffing models. We have different environments. Some people have more care homes. Some people have less. We have or participate in different amounts of training and processes. So I can't tell you why your area has more or less antipsychotic prescribing. What I can tell you is that we thought about all of this when we put the toolkit together. So actually what we did was try to look at resources that support lots of different areas, and you can pick and choose the bits that are going to work for your place. And some of it may not be relevant. So, first bit of the toolkit. We set out some background areas here. We look at a person-centered approach. We look at the shared decision making. We look at what are antipsychotics. We look at the service expectations of antipsychotics in dementia, and we also look at delirium and the use of antipsychotic medication in delirium. So here we've got lots about risk, lots about when to use it, how to use it, guidelines. I think we've got somebody unmuted if you don't mind, because we're recording this. So if you don't mind just muting, thank you. So you can see there's lots of information that we've pulled together, and we've done that to help you to be able to not have to navigate and look for stuff. In the next section, what we've done is try to bring together the evidence and what we know is out there about those non-pharmacological alternatives. It won't have everything in it. And when we do another iteration in about a year, so that's why we're going to probably wait a year. And if you have new services or new suggestions or evidence that ought to be in there, then we will include that in the next iteration in a year's time. But what we've tried to do is bring together what we know of that's out there, different things and different approaches. We spent a lot of time on section 3 trying to bring together de-prescribing guidance. When should you do it? How should you do it? Why should you do it? And we've also looked at other de-prescribing considerations for people living with frailty and dementia, like anticholinergic burden, like the STOP criteria for frailty. So we're sort of being a little bit more holistic than just saying antipsychotics. So really using opportunities with structured medication reviews, and all of us, when we make every contact count, to think about how can we de-prescribe or at least reduce their use, and how do we do that? How do we remove that fear that we have about undertaking de-prescribing? So that section is all about that. The last section is bringing together loads of different tools and resources. And what we've done here is we've coded them to where we think that they're going to be of greatest value. So we've got primary care, pharmacy, care homes, the acute mental health and secondary care sector, and then people living with dementia and their carers. Some of them are applicable to everybody, okay, but some of them are really definitely focused on only one group of people. These are not resources that we've written. These are resources that are out there, all right, but we've put them in one place so you can access them. So if you're wanting to look at audit data and audit tools, you will see that there's an audit tool that we've been using in West Yorkshire, in Yorkshire and Humber and the London network, which we're doing in Bradford at the moment across everybody living with dementia on an antipsychotic. To try and help us at place know what our problems are, what is on our fish diagram, where do we need to use this resource. You can also see, how do you access data? How do you know? You'll be sitting there going, well, what, am I good or bad as a place? Well, through this resource, you can go and have a look. You can see nationally published data about your system. We've put the de-prescribing guidance, we've looked at the non-pharmacological interventions, we've looked at patient leaflets, we've looked at other general resources about what physical monitoring do you need to do for people on antipsychotics. So it's all there, hopefully coded. It won't have everything. If there are resources that you come across that you absolutely love, that you think are really useful, and you want us to consider putting them in next time, send them in. We'll have a look at them. Are they better than what's already there? So that's the last section, section 4. Okay, so next steps. So this is just telling you roughly about the toolkit, but we're going to have some very targeted conversations coming up, and we've got some dates here. They're not exclusively for these groups, but we may have different conversations with these groups. So actually you may find that you're going to be talking to like-minded individuals. So we're going to have a conversation with pharmacists on the 20th of October. That can be pharmacists across practices, PCNs, community pharmacists, secondary care, mental health pharmacists. How do we have that conversation as pharmacists? The second one will be more targeted at our mental health providers, probably those ones that we're going to be asking the advice about the challenging behaviours, distress. And the final one will be with GPs, community staff and care home managers. How do we all work together in the community for people who've been on them a very long time? What's our next steps? How do we have that conversation? So those are the 3 conversations planned. That's my last slide. Oh, yeah. So we've now got quite a long 40-minute period, okay, when we can take some thoughts. So Colin,
I'll stop sharing the slide for now,
yes,
Sarah, so that
lovely.
we can see the questions in the chat a bit better. But I'll just to let everybody know, we will share these slides and the link to the toolkit will be in them. But I'll also drop it into the chat box as well, so that you can all see it today at some point. But I'll just stop sharing my slides now.
Okay.
Okay.
So I can see, and I haven't been looking at the chat box because I've been looking at my slides, but I can see Rachel Thompson's put a comment in there, and I can see Rachel on the screen as well. Rachel, start us off. Tell us about your comment in the chat box, please.
Yeah, hi. So thanks. I just wanted to raise the issue. I work a lot with people with Lewy body dementia, and one of the contraindications that we know for people with this type of dementia is that particularly the atypical antipsychotics can have quite a significant impact. So things like extrapyramidal symptoms, in fact, even as I mentioned, neuroleptic malignant syndrome. So I just noticed on your slide you talked about the use of haloperidol. So I just wanted to raise that just as a flag, really, because I know that sometimes it can get used in delirium, and just being very cautious about if that's used, just double checking. So that was my first point, and the other thing really was just that I absolutely support this as a toolkit. It's really important that we don't misinterpret distress behaviour as psychosis. But again, for example, in Lewy body dementia, I see a lot of people with actual kind of true psychosis as a result of their condition, and I know it can be difficult to assess, but certainly some of the people in the kind of Lewy body dementia field talk about the use of actually a very small dose of quetiapine sometimes being helpful just to reduce some of the symptoms, although cholinesterase inhibitors are your first line of treatment. But just being aware, because I know that's probably is an off license as opposed to a licensed antipsychotic. So again, risperidone we don't tend to use in Lewy body dementia that much, just because I think the evidence isn't there to say it's that helpful. So I just wanted to raise that. Clozapine, just finally, is very cautiously used for people. The evidence is mostly around Parkinson's dementia. So again, just bearing in mind that needs very kind of careful monitoring. But I think that's linked in the toolkit, isn't it, to the treatment of psychosis. So I just wanted to flag that, and I don't know if you've got any comments about use of quetiapine, really.
So I put that slide in only because I don't want you to think that this is all about deprescribing the toolkit. There are some times when they are appropriately used, and it's then up to the specialist prescriber to initiate them. So Rachel said about when we might use things. So thanks for that. I don't want us to concentrate about on when we should use things. I'd like us to talk about other opportunities, really, other than prescribing. Accepting that sometimes we will is probably the way I'm thinking about the toolkit. But thank you, Rachel. That was really useful to just highlight Lewy body especially. I can see some hands up. I haven't taken another comment because I thought it looks like Delia would like to ask a question or have a comment. Do you want to come in, Delia? And then if we've, depending on where we're at, we'll look at the chat box again and other hands up.
Yeah.
Delia?
Shall I just, yeah, sorry, it was just about the haloperidol, because I remember we had a discussion, didn't we, that we didn't want to be encouraging haloperidol for BPSD. So I think in the toolkit, we even avoided mentioning it altogether, but we wanted to kind of acknowledge that it is licensed now. It appeared in the BNF without anyone realizing that it's now licensed for BPSD. But we wanted to be really careful that we weren't encouraging its use or, you know, saying it's safe, because it has been compared in studies with risperidone, and the EPSC, you know, you're a lot more likely to get EPSCs with haloperidol. So we're not really encouraging its use. We don't really use it for BPSD, what we don't in our trust anyway. But I think it just appeared that it is licensed now. So we just wanted to mention that it is licensed in case no one knew. But it wasn't to encourage its use at all, because it's not very well tolerated. There's a QTc prolongation issue as well. Yeah, we do still rarely use it sometimes for delirium, and I think a lot of patients sometimes carry on the haloperidol long term, and people forget to review it and stop it when it's used for delirium, but we don't use it for BPSD. So that's what I wanted to say about haloperidol.
Yeah, you're totally right. I had to update my slides because I'd put that risperidone was the only one with a license, and then I saw it in the BNF and thought, oh, I'm going to have to add that in. So I did, but it doesn't mean I advocate the use. Thank you very much, Delia. That's brilliant. Okay, so I can
couple
see
more hands up.
There are, and I can see what Manisha.
Manish, yeah, thank you.
Manish, sorry, I added an extra A on the end there. Apologies.
That's all right. That's all right, Sarah. Thank you. No, I just want to sort of, I agree with the sort of the general message of the sort of the conversation we are having, in that, you know, antipsychotics should be used, should be a last option really, and actually used for the shortest amount of time needed, and you know, we should aim to take people off and de-prescribe. And I think I'm in agreement with all of that. But I think, like you highlighted, Sarah, the practicality and being pragmatic, and you know, you may well have to use it, and under those circumstances I think it needs to be under a specialist sort of prescribing, and I think that's quite important, I think. But just on the point that the previous sort of comment about haloperidol, it's an interesting one. Haloperidol, I know it's an evil drug, that it's been painted as an evil drug, but I have a different view on it. I think in terms of EPSCs, you know, risperidone and haloperidol, again, it's probably a dose-dependent effect, and it depends on what doses you use. I mean, what we do know about haloperidol is it's quite a potent. So low doses will actually cause significant, you know, receptor occupancy. So it's about dosing, is what I would say about haloperidol. But I think there is another interesting property about haloperidol, in that it is actually probably the least anticholinergic of the antipsychotic drugs, which again is the reason why it's used in delirium. So I just want to be sort of very clear, but in my practice, I mean, I think I probably use risperidone more than haloperidol. I'll put my hand up. But certainly, if you think about the actual pharmacology of the drug, it's probably got more of a bad reputation than it ought to have. And there's certainly a role for it if used appropriately in the right doses. And like I said, it's to do with the anticholinergic properties and things. That's my view anyway. Thank you.
I was going to make a comment, but I can see, Amanda, you're going to make a comment first. So do you want to just come in there? Mute.
Sorry, I wasn't actually going to come in with regard to haloperidol. I was really going to come into the comment about if you are initiating any antipsychotic, then it's really important to have a discussion with the relatives or the next of kin if the person themselves doesn't have capacity. And invariably, when one's prescribing, it's often the case that they don't have capacity. But if they didn't have capacity, then it's really important you go through these risks and discuss them. It's not putting somebody on a drug and nobody knowing. And it's really important. And I know that Sarah's very, has already stressed that, but that is something. And it so many times I've seen people who are on medication, it's not really quite sure why they ever got on it, but then everybody goes, oh, you can't stop it. And actually, if you do it very slowly and you monitor the situation, they can come off it and they don't need it. A lot of these symptoms will go away if given time, But obviously, if they're causing a lot of distress and putting people and the person themselves at risk, then you clearly have got to do something. So that was what I wanted to say.
Yeah.
Sorry.
No, and that echoes what I was going to say. So we're carrying out this big audit in Bradford on everybody, and one of the things we're noticing is lack of shared decision making, and lack of sharing of risk. You know, we're quite paternal, aren't we? We think we know best, and actually we should be sharing risks and benefits with families and people living with dementia. We've probably done that less than we should do. I can see a comment from Steve. Should non-pharmacological measures, oh gosh, it's zipping up the chat box, have gone first? Well, section 1 is trying to give you a bit of background. So it talks about what are antipsychotics, what the risks are, shared decision making, and then this is not a how to manage distress behaviours toolkit. This is about the appropriate prescribing of antipsychotics. So that's why we put non-pharmacological next. So I hope that answers Steve's question. I just saw that in the chat box. Okay. So has anybody else got any hands up that they would like? And then we could, if not, we will take some. We'll have a look at some more comments in the chat box. Has anybody got any other comments or questions?
There's Helen Pratt's got her hand up. Sarah.
Hi, Helen.
Do you want to come in?
Hello, I'm struggling to get unmuted. Am I unmuted? Can you hear me?
Oh, Helen.
Lovely. Thank you. Wonderful resource. So thank you so much to colleagues for sharing this with us today, and we will certainly be using this and taking it forward in conversations in Greater Manchester. Just out of interest, because I've been speaking to clinicians recently, I'm a project manager with Dementia United, so quality improvement programme, but people are moving from using antipsychotics to using other forms of sedation. And particularly because an area of work that we've been doing in Greater Manchester in delirium is I'm hearing that people are using lorazepam and and trazodone. I don't even know why trazodone suddenly being used a lot more. And I guess this toolkit was designed to address the antipsychotic prescribing, but what people seem to have been doing is they've been shifting onto use of other medications, and I don't know what people's thoughts are around that. I'm not suggesting that I have a view either way, but the use of sedation brings with it so many problems and is a concern. So I'm just interested in thoughts on that.
I'm going to tell you that I haven't looked at recently, but we had the discussions about the risk of pushing people into alternatives. Can't remember how much we put in the toolkit about it. I will have a look, but we did definitely discuss it in the steering group because we recognise that that's often, well, that's what's happened in other drugs before, hasn't it? We dislike one, so we push into another, and the risk that they, so I think under the deprescribing section where we talk about anticholinergic burden and frailty and stuff like that, we do look at that. But if not, I will double check what we
and I suppose it's for us to use the toolkit, Sarah, and feedback, because if we are finding that, I think it might be something that we want to incorporate moving forward. And we've written some guidance around non-pharmacological prescribing for distress behaviour and delirium and keeping people away from medication. So, you know, we can share all of those resources so that people can have those regardless of the use. So, but thank you.
Because we want it to be current and we want it. So I can see that I can only look at hands up or chat box. It's terrible, isn't it? Right. Okay. So is it Varia? I'm just seeing.
I was going to say there's
Russ. The first name here, but
Varia, sorry.
Oh, Varia. Sorry, I could only see Russell White because it starts off at the beginning, and I didn't want to. So you have a comment or a question?
I have a question, please.
Yes.
So yeah, I think the previous speaker before Helen, she alluded to this question. So it's about antipsychotics in dementia. I currently have a patient who's been on antipsychotics for over 2 years, and I'm just wondering, when is the time frame actually to review that? Because it was initially prescribed because she was quite distressed, but now she's in a care home. She's not always settled, but she is still on the antipsychotics. It's a very small dose. She's on risperidone. So I just wondered when will be the right time to review that medication in her case because she has dementia.
Okay, so I'm not a psychiatrist, okay, but in my view, as a GP working in care homes, the next time you go in, or soon, should be the time to start looking at it. And what the toolkit does is gives you methods of deprescribing and how to actually go about it. Is it appropriate? Because I don't know this individual, because you need to talk to carers, you need to talk to families, you need to talk to the patient, and actually come together with a shared decision making about how you're going to deprescribe. So the toolkit has a whole section on how to get ready to do that, how to do it, how you might reduce a dose, halving it, stopping it, quartering it. So there's different methods, and how might you support people to do that. So hopefully you'll find that section of area really useful, and do feedback, because we want to know if there are other resources out there on that section. So I hope you find that bit useful.
Sure, thank you.
I've got a hands up from Anne Bentley from Airedale Digital Care Hub. Do you want to come in with your question or comment?
No, thanks, Sarah. Can you hear me okay?
I can.
Oh, perfect. Thank you for this toolkit. It's really well needed. Just a few comments and questions, really. One comment is, sadly, where I work, Digital Care Hub, we look after residents in 800 care homes across England. And the number one reason we get calls is for falls. And many of those residents are prescribed antipsychotics. In terms of the shift from antipsychotics to trazodone and benzos, lorazepam, they're taking all of them. They're being prescribed in combination. So that's a tragic reality coming out from the care homes across England. The other thing I'm seeing, and I don't know if there's any comment in your toolkit about it, is triggers to review. So one of the things I see quite often is adding another medicine to manage a side effect. So this morning it was hyoscine patch with an anticholinergic burden of 3 being added to manage the hypersalivation of somebody who was condemned to risperidone. So I wondered if there's anything in the toolkit or any comments around the prescribing cascade and actually adding in other medicines to manage the side effects of the antipsychotics. And that finally, just something about whether falls specifically is mentioned as a trigger for review, because obviously that's quite a very common experience, and whether there is any guidance for the specialists around how they communicate around medication review, and automating that in some way. Just, sorry, a number of questions there.
No, that's absolutely perfect. So the section on prescribing. So I hope you will join us, Anne, when we have that webinar, because I suspect you'll have lots of pharmacists there. The section on deprescribing, as I said, we took quite a holistic approach, because I don't think antipsychotics sit by themselves in older people, which is what you just said. The whole anticholinergic burden, the whole sort of frailty, unnecessary medications. We've looked at how you deprescribe. I will have to look again in detail about whether we've suggested, other than medication reviews and it being a good thing to deprescribe, whether there are other triggers. So I will take that and have a look at it, and hopefully, Anne, be able to give you a bit more detail about how much we've put in that section. Delia, are you able to help me out here about anything else in that section around those triggers? Did we put any trigger tools?
I don't know
in
that
that
we've
section?
mentioned falls. I can't remember if we mentioned falls as a trigger, but we did mention anticholinergic burden, and we put the links to the scales and the electronics, ACB calculator and the AC MediCheck. So we do mention anticholinergic burden and to review and to try and keep it low and all that. But I'm not sure that we specifically mentioned that it should be a trigger if someone has a fall, but we could probably add that. That's probably a good point to, that.
Yeah, it might be the next iteration. Amanda, you probably read through it more recently.
No, I was really going to comment. The New World Falls Guidelines came out last week, yes, and it actually says everybody in a care home should be considered high risk of falls. So I think there is so they're saying, don't worry, everybody should be in the care home. So I think that there is increased recognition of the need to review medication for people in care homes with regards to that particular risk. I was wanting to really support what Sarah had said in response to Barry's question, and it's about reviewing medications really when you can, at least 12 weekly is what the guidance is really talks about, and that we have a process in place generally for doing that, for being able to say, right, let's review. It's really helpful, and that's the whole bit about initiation. If you understood why the person went on it, so then you'd know what symptoms you were actually trying to see whether they're responding, because there's no point in giving somebody a drug and then you're not even maybe for aggression, and then you're not even recording what's happened. Maybe the aggression was going to stop anyway. So you then need to, as Sarah's very kindly explained, gradually reduce and look for the response. And most of the time, you know, the evidence shows that you're not actually, their person's not going to need it.
Thank you very much, Amanda. So coming up with some more people with questions. I've got Julia next. Julia Grant. Do you want to come in, Julia? Or comment?
I'm Julia Grant. I'm a consultant in palliative medicine in the Southwest. I did put a comment in the chat about specialist palliative care often not being available to patients with dementia for lots of different reasons, often because we don't feel like we've got the skills or the capacity or the resources to support patients. But also the anxiety I often have that we are perhaps a little bit more generous with antipsychotic drugs because we're more familiar with them at the end of life. So we perhaps use them too early. I'm kind of aware that, sorry, my dog's barking, I'm aware that toolkit's accessible by signing up, but just a bit anxious that actually there are groups of service providers who won't know about this, the availability of things like this, and perhaps won't be signing up to this sort of resource to know to be able to use it. I just wonder whether there's a way of making it more freely available nationally, so that it's there for people who are not expert in this to be able to get the support that they need.
Absolutely. So I know, because I've seen comments flying in the chat group, that Claire Fry is on the talk today. So Claire, I'm sure, will look at cross-posting it on futures with, there's a myriad of different groups, aren't there? And Claire does cross-post between sort of enhanced care and care homes and things like that, but we'll look at the palliative care network. Just so that if people are worried about those antipsychotics and think that they could be because of palliative care, we deliberately have removed the sort of subcutaneous end of life medications and doses from the data around people generally being prescribed it. So areas can be assured that it's not just picking up people who are living with dementia and on the end of their life. We've excluded those medications. But yeah, it'd be interesting to see whether we need a bit more of a focus of how to use them to manage distress towards the end of life, and that might be another section to have in the toolkit in a year's time. I hope Tony's writing all these good thoughts down.
Yes.
Thank you, Colin. Okay, so thank you very much, Julie. That's much appreciated. I've got two more people in the chat box. Well, no, with the hands up. I've got Annette, and then I'll come to you, Emma, after that. So Annette, where are you and what would you like to say?
My name is, what it is, I work for a specialist dementia team, intervention team in South Wales.
Hello.
So there's quite a few of us in this group watching this, and it's just what it is. We have got a toolkit, but our toolkit is all about interventions such as music, doll therapy, all those things. So our role is to we carers focus, and we help them manage the behaviours, the challenge, with different things in our toolkit rather than medication first. I was just wondering, is this something that you've got in England?
Yes, so we've got a section. Oh, I'm getting some echo.
Yes.
A section on anti and non-pharmacology. Can I ask everybody just to mute? Sorry, Annette, do you mind just muting? Because I think we're getting awful feedback. So we've got a section on the non-pharmacological measures, and in that we've got things like music and doll therapy. We also talk about clear dementia mapping. So anything that we've got evidence for or documents out there that we know about, because we don't know about everything, we've put in that section to help you look at the non-pharmacological measures. So I hope that people will find that section useful. I'm going to move on now to a question from Emma. Hi, Emma.
I'm really sorry I missed the first part. Hello, Sarah and other people.
Hi.
I haven't seen you for a
Fine.
while. So I'm sorry if you've mentioned it already. My query is there mention and how does it link in with other deep prescribing tools such as stop start? Because I'm just thinking, how does this fit into kind of everyday practice? And our pharmacy colleagues would be very helpful in that. And then my second related query is, have we linked in with the is it Association of British Pharmacists to share the toolkit, because our pharmacy colleagues could be really helpful in, potentially prompting. And you interestingly mentioned an example of the prescribing cascade, which one of the purposes of deprescribing is to stop us getting into those cycles. So
so I absolutely can assure you that when we wrote the deprescribing section, and we had a great lot of debate about whether it was beyond our remit to go wider, but I believe holistically that we should. So it's got very much a lot about anticholinergic burden, stop, start, general how to deprescribe, structured medication reviews. So it's got all of that within it. Delia, do you want to wave your hand, because you are our sitting on our steering group, representing our pharmacy colleagues, and we're going to have a 1 hour conversation. It's very much around having that probably a bit more in-depth conversation about from a pharmacy point of view. So Delia, yeah, you're there. I can see now on my screen. So you're representing. That's all right.
I just missed the beginning of the question. Were you saying has it been circulated to was it the other pharmacists or the British Association of Psychopharmacologists? Is that the
whatever the British Association for Pharmacists is, whatever it's called, I can't remember.
Yeah, no, so I mean, there were some pharmacists obviously on the team that put it together, and also, yeah, like you said, there's going to be an hour discussion with all pharmacists. So I guess we'll get feedback then. Yeah.
But we've literally only in the last 24 hours probably actually now got it posted, because we had some typos and things. So once it's out there, we will be pushing it and sharing it, and hoping that you will push it and share it, and suggest places we can share it. Okay, I look like is it Varia that you've got another question? Forgive me if it's a legacy hand.
It is legacy hand, yeah.
Oh, is it there? Never mind. I'm used to those. I'm being still on mute as well. I'm priceless at that, even after 2 years. So are there any other questions on comments? If not, we're going to probably look into the chat box. Don't be shy. There's only 320 people. Sandra, I can see a proper hand.
Sarah, there's a couple of hands there. I don't know if you
there's
missed
a couple
them.
of hands there as well.
Okay, so let's start with Sandra, because I can actually see the hand there, and then we'll go and then I'll go on to Harry after that. Sandra.
Oh, yeah, I'm an admiral nurse. I work in Lancashire. I recently worked in an acute hospital setting where we had a lot of people with dementia, with delirium, older adults, but a lot of my experience was around recognising the potential need for pain assessments to be completed and pain ruled out as a cause of the distressed behaviour, rather than jumping straight to an antipsychotic. And that's something really that I want to maybe highlight, something that needs to be looked at alongside, even during the use of an antipsychotic or anxiolytics, to make sure, because they don't act on pain receptors, don't antipsychotics, we know that. So why not look at the cause? I think a lady's already touched on that point, looking at the cause of the distress behaviour, because it's not always around psychosis. A lot of it can be, particularly around behaviours, resistive behaviours, shall we describe them, during interventions, during personal care. Can we not, make sure that's included in the toolkit to rule out pain?
Absolutely, and I think that's why I use this expression distress rather than challenging behaviours, because challenging is about how we feel about them, and distress is what actually the patient is experiencing, and it's about understanding that distress, isn't it? If people have tools and resources that they feel when they've looked at the toolkit that they want in the next iteration in a year's time, that maybe, you know, because that section at the end, this isn't a textbook about how to deal with everything. It's about bringing together resources so that if you haven't got something, you can find it in the toolkit. So Sandra, if you have stuff like that, then by all means share it. We would love to see it. But absolutely crucial what Sandra's saying about pain. And can't thank you enough. I'm probably going to take you with me and remind people about thinking about things like that. Okay, so I've got a few more hands up. Harry, do you want to come in? You've been patient. Have you got a comment or
Yes, thanks. Yes, thanks, Sarah. One was just to echo what Sandra just said, and my comment was linked to that. We've just written a distress in dementia poster for use in the Hull and East Riding area in conjunction with the mental health teams and the CCGs have written it. And it's a poster to be used for both primary care doctors, because I think the toolkit's fantastic, but it is quite, the poster was designed to be something that GPs may use on their 10-minute home visit. And it's also for the care home staff. So it follows through both the non-pharmacological management, but also some advice around the pharmacological management. And my second point was, I don't know if anyone else has a comment, is one of the things we find when we're trying to de-prescribe within the frailty team around antipsychotics is that we have quite a lot of resistance from care homes and on occasion family members, because the residents are now are sometimes settled and they perceive that to be due to the use of the antipsychotic medication, not that the distress may have settled anyway. And it just can be tricky to start de-prescribing. Thank you.
Absolutely, Harry, you're right. And I hope that your poster, if you can, when we do the next iteration in a year's time, lovely to have those kind of resources, including it, quick aid memoirs and things. De-prescribing is emotive, isn't it? And I suspect when we have the pharmacy meeting, we'll be talking about that. And we were talking about it in one of our Bradford meetings, that actually people find it really difficult, easy to prescribe, really hard to de-prescribe. So I think what we've tried to do is include in the resources section of the de-prescribing, where we've found good leaflets, where we've found good ways of managing the de-prescribing. You'll find them in that, you know, ways to try and influence people and try to, my own personal thing is go small, go slow, go at their pace. We probably all have little things like that aren't informal guidelines, but we've put some approaches within that section, and no size fits all, but some being a bit more shared decision making will.
Sarah, if I can quickly come on that point, because that's a common thing, because I didn't probably mention, I'm a psychiatrist working in Essex, and I'm part of the dementia crisis service. So this is a situation we come across quite often. Getting people off is quite emotive, partly because they probably had significant distressing behavior before, and people are very anxious. And the whole thing there is about actually having those joint conversations, care homes, family, and actually taking them along with the decision making and trying to explain to them. And that's what mine and my sort of team's practice is, that we will be doing it slowly. And if there's any recurrence of symptoms, we'll review it and do the needful. So that kind of reassurance helps people bring, sort of help us make the decision together. I think that's probably the key thing to sort of consider when faced with situations like that. Slightly another point about de-prescribing I want to make as well. I mean, one of the common things that I tend to see is that people have been started on various medications, not just antipsychotics, for whatever reason, for a particular symptom, but then it's not reviewed and the symptom doesn't resolve and another medication gets added on, rather than actually taking people off the first medication. And that's partly because people are not necessarily being reviewed after the medication's been started to see actually, has this benefited them in any way. So that's a common scenario I come across, and one of the things I tend to do in my team is to actually go through the drugs, see if any of them has had any benefit, and if not, take medications off if they are not benefiting people.
Thank you very much. That's really helpful. Amanda, did you want to come in there?
Well, I was only really going to echo what has just been said. It's that bit about the trust. If you say I'm going to de-prescribe and I'm off and I'm not going to be there to support you, then it's not going to work. If you have, and we'd hope thanks to this toolkit, there's clear structure about why it was prescribed, then you can then say, well, look, we're going to try and cut it down, but let's see, let's monitor. Don't do it all quickly. It's not like, you know, the next day you keep cutting and then nobody will visit again. It's there knowing that you'll be there to support them. And honestly, when you've explained the risks, the care home staff don't want those increased risk of chest infections, falls. They don't want them, and nor do the relatives. And so they will give you that opportunity to have a go at reducing, providing you're there to support them.
I agree. I think, and one of the things we're looking at in Bradford is a support mechanism for people who are trying deprescribing, because one size doesn't fit all. People will have things that work with, but other times when they found it more challenging and think they want to give up and never do it again. So we're going to have a sort of support group for our pharmacy colleagues, which will be supported by Anne, who's sitting here on the call, and other very senior pharmacists who can give support to people trying it out. So that's one of the things we're going to try in Bradford.
There's a couple of hands still up, Sarah.
I can see that. One is a legacy hand, I think, from Annette. I've been ignoring it because I've assumed it was a legacy. So I hope so. But if it's not, Annette, do come in now. But otherwise, you can remove your legacy hand. And then I've got, it is a legacy. And I've got Sheba wants to come in next.
Hi, Sarah. I think other people already asked that question. It was raised before my colleague raised one of the points. There is often anxiety around taking people off antipsychotics, but also sometimes when we have behaviors, particularly in care home, which challenge us as well as the care home staff. I think I often feel that we tend to prescribe for the anxiety of the staff who are looking after this patient rather than the patient itself. And often I'm challenged by the question from the care home staff that you come, review the patient, and you take a snapshot, but we are here to deal with this behavior all along the line 24/7. So how do we feel supported? And I was really pleased to see at the beginning, Sarah, you mentioned that we are going to have those conversations with the care home managers as well, because I think it's not just about the pharmacological management that needs to be put in place. It's also about that additional support that would be needed to tend to the behavior of the patient for maybe 6 weeks with the help of one-to-one care. That's going to be really a key in supporting us as clinicians to avoid prescribing these antipsychotics. And I had another point to mention. I have also seen, including myself, prescribing promethazine for the agitation and aggression. And there is a trend of increase in use of promethazine instead of lorazepam or other benzodiazepines. Promethazine has got the anticholinergic load of 3, but we are conducting a little audit within our trust to see the use of promethazine, and should we be kind of avoiding that as well? And is there a place for promethazine in your toolkit to be addressed alongside antipsychotics?
So I think in the toolkit we put about anticholinergic burden. I mean, I think what we need to do is almost tie our hands behind our back and not resort to just something else, a pill for all ills. And actually, you know, if we know things don't work, then actually we're appeasing ourselves, as you say, but also, you know, supporting people who are working in an environment where they're encountering distress all the time is distressing if you work in that environment. And quite hard, and so there's, you know, and lots of training and poor wages. And so yes, we have got a conversation for community staff, which it would be lovely if people would join, where, you know, we will talk about with our care home colleagues. I'm conscious that we have got about 3 minutes, before we end. Anna,
we've got
yes, Anna, have you got one very short question or comment before we wrap up? Because
Hi, I'm a psychiatrist in Chester. I just wanted to mention that I have used a variation of this sort of toolkit before in the past. And I think it's in the comments where people have reflected it's a really difficult time because there's such a difficult social care situation where you want to keep people in their own homes or you don't want to move people into different placements, and there are basically no beds anywhere. So I think it is a very difficult time, but when I've used a variation of this in the past, having something that you printed off that you can give to a care home staff member that sort of goes through some guidance, some evidence base is really, really powerful, because at least then you can take it back to the person-centered part of saying, well, actually, it might be that they do see that distress. We understand that they're there all the time, but it's the evidence base that shows that this medication isn't the solution. So I think that that's quite useful and powerful. But thank you, this tool looks amazing.
Oh, thank you. I hope that you will find it useful. I think I can see that people have been trying to download and people are posting, so we will make sure everybody who's joined has access to the toolkit. We're not likely to revise the toolkit before 12 months time, because what we want to do is get a chance for people to use it, tell us what's useful, if there are new versions of things out. But in a year's time, what we'll hopefully do is look at where we can add to it. And already you can see that people have got some really useful comments: falls, pain, supporting staff to manage and cope with behaviour, and managing distress may be another aspect that we can bring in to the section for care homes. So please do send us your resources. We haven't yet got an email address for that, so we'll have a think about that, about how we can get you to send in resources. Please do let people know about the other sessions that we've got. Depending on the success, we may have other sessions as the time goes on, but those are the ones we've got planned at the moment. Is there any other comments from you, Amanda or Colin, before I say thank you to everybody for joining?
No, I just think it's totally brilliant, and hope everybody can use it and disseminate it. So thank you all for all your hard work, you and Colin and the team, London and Yorkshire. Thank you.
Thank you.
Just to quickly say, Sarah, the apologies for people who are having difficulty accessing the tool. You do need to have an NHS Futures account to get it. But in the next couple of days, it is going to be hosted on the London Clinical Network website, and you won't need an account for that. So we will, everybody who's joined today, we will send a link out to you, including the slides from today and the recording of the meeting as well. So yeah, that's all I wanted to say, really.
Lovely. Well, I'll let everybody go and have some lunch. Thank you very much for being such a fabulous audience and participating so brilliantly. Have a good break if you've got time before your next meeting or work. Okay, take care, everybody. Thank you very much.
Thanks to you too, Sarah and Amanda, for wonderful chairing as always.
Thank you. Bye bye now.